So, good morning. I would like to welcome you to the wrap-up interview on TransAortic valve implantation. I don't need to introduce my colleagues, Dr. Makkar from Los Angeles, Dr. Alain Cribier from France, Rouen, and Thierry Lefevre from Paris. We would like to go through a few slides, and then we would like to cover a few topics on TransAortic valve implantation. The issues in briefs are summarized on this slide. The indication of TAVI. We would like to address the current indication, the heart team approach, clinical studies briefly, and then future perspectives, and then the TAVI outcome of those FDA-approved devices, cost effectiveness, and new technologies. You can see here what we experience in Europe, and you can see here an increase in the US and in Europe with the TAVI procedures, with the growth from 2010 to 2015. Those are the two approved devices. The only FDA-approved device is the Edwards Sapien. The Corevalve is under investigation in the US. In Europe and outside the United States, the two devices are approved. We have a consensus on TAVI indications, and that is class 1, that there is a heart team required. There should be an on-site cardiovascular surgery, and the patient should be inoperable, decided by the heart team. Class 2A is high risk as an alternative to surgery, determined by the heart team, and case-based decisions. Contraindications in the society, there are absolute contraindications and relative contraindications. I don't think we need to summarize those because everybody can look them up. The partner trial is the first randomized controlled trial for the Edwards valve with the cohort A and the cohort B being inoperable, cohort A high risk. We know the results and can discuss this in brief. All mortality at 1 to 2 years in the inoperable group, and we can see here the standard therapy, which is the medical therapy, including balloon valvuloplasty and TAVI, and you can see that those curves are spreading after 1 year, and that continues up to 2 years with a marked difference of 43.3%. The all year in the high-risk group is actually in the beginning, there was a separation between surgical valve replacement and TAVI, and then after 1 year, those two curves are overlying each other. The registries of the Edwards Sapien are summarized here: the Revive, Revival, and Partner EU, the Source Registry, the France Registry, the Belgium Registry, and the Canada Registry. Medtronic Corevalve Registry are summarized here: the Tamburino, the Milan, the French, Spanish, UK, Ireland, UK, Germany, and a publication by Dr. Büllesfeld from Safety and Efficacy way back. TAVI outcome at 30 days, looking at the VARC meta-analysis in 16 studies with 3,500 patients, are summarized here with a mortality, stroke, bleeding, vascular complications, and pacemaker rates. Those are the gradients, the hemodynamics, the mean gradient, valve embolization, very rare, but it does occur, conversion to surgery, and coronary obstructions. Partner 2 is the intermediate risk group in the Edwards trial, and the TAVI intermediate of the Corevalve trial. Both studies are ongoing, and we will see what the results hold. Basically 2,000 and up to 2,500 patients. New devices are on the horizon, which might actually address some of the previously discussed complications and issues. So with this, I would like to start the discussion, and we have about 30 minutes, and please, if we could keep our answers short. Raj, what do you think about the increasing penetration rate? What's your comment in Europe and in the US?
Well, in the US now we have almost 200 sites that are certified for implantation of the Edwards valve. In addition, there are about 40 sites that are participating in the Corevalve trial. So as is quite obvious, in the last year or so, the number of sites and the penetration has really ramped up.
So Alain and Thierry, what do you think? The penetration in Europe is well known due to the two approved devices. Would you expect the same in the US and outside the US, apart from Europe?
Well, actually, I think that the penetration will be quite comparable, but there is Something else that has to be taken into consideration is the reimbursement of the valve and the cost of the devices. So it means that this will certainly slow the rate outside Europe, especially in Mid-East and in developing countries, of course. But the penetration rate in Europe has been absolutely amazing. It's an exponential curve. For example, today in France, Thierry, if I am not giving the wrong number, I think in France we're implanting 3,500 valves every year. Something like this in 40 centers. So it's within 2 years, the number have almost doubled.
So the reimbursement is quite different across Europe, even though we have a European Union, but the reimbursement is very different in those countries, reflecting what you said. The penetration rate directly reflects the reimbursement because obviously hospitals don't want to make minus. So we'll have to see, but as a procedure, it's quite attractive and we expect a high penetration rate. Suppose reimbursement is guaranteed.
Yeah.
Okay, an interesting question, Thierry, the heart team. I mean, is this the reality today in Europe that the heart team really makes the decision, or is this just a guideline, a recommendation?
I think it's both. Today, the recommendation is to have a heart team to make the decision. Then sometimes it's not completely the heart team, unfortunately, but I think it should be the heart team always.
Well, we have really strict indication to say, and this is coming from last year, in France at least, that the heart team has to take the final decision. So this has to be really scrutinized, and we have to make a report with the signature of the participants. So it's very, very severe. I mean, the heart team is there for the indications. Now, concerning the heart team for the procedure, it's a little different because from one team to another, we can observe that some people are doing, for example, general anesthesia, some other are doing local anesthesia sedation, so the same people are not involved. In many places today, the surgeon is not in place, in spite of the fact that the recommendations say that the surgeon has to be here. But actually, this is not what is observed in many places in Europe. I think that in the United States...
Yeah, I think this is reality that we see as the procedure has gotten better. With less complications, the surgeons do their job and we do our job, and in case we need help, we support each other. Do you provision that actually the same that we see in PCI, percutaneous coronary intervention, will eventually happen in TAVI?
We evaluate. First, let me go to the issue of evaluation. So every patient with aortic stenosis at my hospital gets evaluated by both interventional cardiologist and a surgeon, and we actually have no choice to satisfy the CMS guidelines, but to in fact have a note by 2 surgeons that certify the patient to be either inoperable or high-risk operable patient. So we have no choice there. In addition to that, depending upon the institution, more so at ours, we actually work together and the surgeons will actually participate in the procedure with us. So that might change in the future, but at least as of now, the interventional cardiologists and the surgeons are actually working together in the cath lab.
Okay, so coming to the next point, Thierry, we discussed this morning in the workshop, in the breakfast meeting, the 2 valves, the Sapien and the Medtronic Corevalve. Would you be kind enough to summarize maybe specific indications or differences between the 2 valves?
Yeah, I think both have some advantages and some limitations. I think with the Edwards, there is a higher risk of coronary occlusion and annulus rupture. On the opposite, low risk of AV block, a need for a new pacemaker, and a low risk of aortic regurgitation. With the Corevalve, there is less risk of coronary occlusions and annulus rupture, but more problems with aortic regurgitation and valvular embolization also.
So I'd like what Dr. Makkar said this morning, kind of a bullet point, and no, it was Corrado Tamburino who said the Corevalve is a little bit more versatile and the Edwards is more predictable. Would the three kind of agree to that, or would you say this is not really true?
I think it depends. It's a very personal thing. And I think it is what you have experience with. I personally think that the Edwards valve is very versatile because you can actually put it in different locations and you can put it through different routes, antegrade, retrograde. So I personally think it's a very versatile valve. Though the position, you get one shot, you also tend to get one shot with the Corevalve, at least at this time. So, but by and large, the embolization rate was 0% in the PARTNER 2 trial with the Edwards valve. So I think it's fairly predictable too. So I think once you learn how to use it, I think it's quite predictable.
Personally, I would say that it's very difficult today to compare the two valves because we have a need of randomized trial and it does not exist. So the result that you can obtain with the Sapien or the Corevalve are totally depending on your experience with the devices. I think that definitely from the literature we have the feeling that the Corevalve is associated with more pacemaker. So when we say more pacemaker, it means that the valve is too deep inside the left ventricle and that this may impact also the mitral, anterior mitral valve leaflets. So I am personally a little concerned about the mitral valve leaflets. I think also that we can conclude that the Corevalve is associated with a little more aortic regurgitation as far as we can believe in the data of the registries. The Corevalve has some other advantages over the Edwards. For example, covering large size annulus, for example, it's probably better when the valve is when the annulus is very large. It has also an advantage in when you do what we call valve in valve, I mean for repairing the surgical bioprosthesis, especially in small sizes because of the supraannular position of the valve inside the frame. So it seems that the results in small size surgical valves are better with the Corevalve. So we have some argument like this. The Sapien would have the advantage of being closer to a surgical valve, I think. Respecting the adjoining structures and offering a better opening of the valve with maybe a better coaptation of the leaflet. So this is something that will remain to be assessed.
Just add something. I fully agree that positioning with the Edwards is really reliable. So we know exactly where we should put it, and we put it exactly at this place. The Corevalve is a bit more difficult and you need a lot of experience to put it at the right place to decrease the need for a new pacemaker. I'm sure, Eberhard, you have a low rate of a new pacemaker, but it needs a lot of experience.
Okay, so coming to the next point, because we have to kind of wrap things up, the intermediate risk. How do you feel? Are we ready, or are we not ready? And if we have the two randomized trials, PARTNER 2 and SORTAVI, which will take a while, what are we doing in between for the next 2-3 years? What are we waiting, and until then we stick to the high risk and inoperable, or do we see a risk creep?
I think we have the challenge of finishing up 2 big trials, almost 5,000 patients. PARTNER 2 trial is 13,000 patients in, another 700 patients to go, and then of course you've got the Corevalve trial. So we have some time before we can actually finish these trials, and I think it'll be prudent to wait to see at least the early outcomes. I don't think we need to wait for 2-year outcomes of PARTNER 2 trial. If there are differences in 30-day mortality or some other analyses that actually indicate that it may be safer or otherwise, then the results may actually be guided by those results, or the practices may be guided by those results.
Okay, basically in agreement with what I said?
Well, more or less, I would say that today I don't know exactly what is an intermediate risk patient. For example, you take a patient who has a Euro score of 20%, he is a high-risk patient. If a Euro score of 19%, he is an intermediate risk patient. This is for me totally ridiculous. So I think that instead of saying intermediate risk patients, I think the indications of the valve has to be taken according to good clinical practice and good clinical sense, according also to the opinion of the valve team.
Yeah.
I think it reinforces the need for our team when you will go to low-risk patients. The our team will be, I think, very important.
Well, unfortunately, it's being defined now with accordance to the FDA and the European agencies that, we have the scores, and defining the scores, plus other factors that might actually be introduced by the studies, frailty and things like that, neurological workup. So we're for the time being anyway, we stay to where we are now and wait until the early results come out, given the limitations of all these trials. Now we come to the last 3 points, the new devices. Quite exciting. We've heard some new developments. Would you kind of discuss these new devices for us?
I think it's very interesting because we have now new generation devices, a lot of new devices, and many studies are ongoing today. They plan to solve some issues such as AV block, aortic regurgitation, repositioning of the valve, etc. So we need to see the data now.
But do you think that many of the present issues that we have, I call them issues, not necessarily complications, but the issues that we have with these devices, do you think that for the most part they are going to be resolved with the further development of the present ones and the new devices?
I'm sure that with downsizing, for example, will decrease the risk of access site complication and probably increase indication for transfemoral approach with 14 or 16 French devices.
Alain? Yes, my answer would be definitely yes. We are on the way of solving almost all the problems. Vascular complications with downsizing, as Thierry said. We have the problem of valve migration, aortic regurgitation will be solved with the new devices absolutely well, and also with new imaging technologies for better positioning the valve where it has to be done. We have the problem of pacemaker and block that will be solved by also imaging technologies and new devices. So I am very, very confident that most of these problems will be solved within a very short time. The problem of stroke will remain probably an issue, and I am not sure that we can decrease the stroke rate to below 2% because we are dealing with aortic valve, with bad aorta, with carotid arteries and so on. And I think that this will be the most difficult complication to be solved in the next future.
Raj?
I agree with Alain. I'm very confident also. I think it's going to be interesting to actually look at the newcomer devices and look at the colossal experience that has now been gained, almost 100,000 patients that have been treated by so-called first-generation devices. So while we will continue to solve some of these problems, I think the durability data from the first-generation devices might begin to look very attractive as time goes on when you are actually looking at newer devices.
Also, I think it's fair to say that we have an extension of the valve types. We cannot simply say now the new valves are either balloon expandable or self-expandable. If you take the direct flow, has nothing to do with either one. The Sadra, you might discuss, maybe they call it a hybrid valve. So it's not only the material, but it's also the type, I mean the engineering part that might be different, but all go into the correct direction, solving issues.
Absolutely, yeah.
Okay, so how important actually do you think guidance imaging is, and how did this evolve over time?
I think imaging is critical. It's critical for planning the procedure, for access, for sizing of the valves, and then it is very important in terms of actually the procedure itself. What angles to choose when you deploy your valve. So for all of these purposes, imaging is absolutely critical, and I have to say that I am very CT biased in terms of planning the procedure. CT is the best imaging modality. If you don't use CT, I would make the argument that you should try and use 3D echo as much as you can during the procedure so that you can make right decisions while sizing the valve.
Alain, from my own perspective, you as a pioneer, you certainly did not start out with CT measurements. So you used echo. Did this evolve over time? Are you agreeing, or would you say echo is still good enough?
No, absolutely not. No, I am now using a CT on a regular basis, not only for selecting patient, but not only for selecting the approach, but also for selecting the valve size and so on, as anyone. I believe that the image guidance is absolutely crucial, as you said, for in two different aspects: selecting the patients, and doing the procedure. And at the last minute, these new imaging technologies like the Philips Navigator, any kind of navigator that are today available, help in positioning the valve and very well. And for the accurate positioning and sizing, it's absolutely crucial.
Thierry, would you agree?
I fully agree with MSCT. The limitation is the quality of MSCT. So it depends by center to center. The quality could be different. So it's very important to the cardiologist to invest in the knowledge of MSCT.
So here we have 3 experienced TAVI users and valve users and proctors. We also know that the reality today outside Europe and outside the United States is certainly not CT angiograms in all patients. So what do you think? Do you think that we should take some kind of a minimalistic approach and accept minimalistic approaches prone to errors? Or do you think, no, the centers that are doing this, whatever country we talk about, should have the state-of-the-art technology?
I would push toward this direction, yeah. CT must be in the department, as well as cardiac surgery. I mean, this is the normal approach to TAVI. You have to have CT for the, actually at least for the selection of approach, which is extremely important. And also for valve sizing, which is a major aspect. Not a single way of sizing the valve. You know, the CT scan does not summarize all possibilities, but we have some other ways, and we have to combine some different image guidance, you know, for selecting the valve size. But CT must be there.
Okay, how about poor man's measurement? If you put a balloon in and inject into the aortic root, and you don't have any leak, would you accept that?
Oh yes, absolutely. Well, this is part of the game, you know. In addition to echo and CT scan, personally, I'm doing balloon sizing in all the patients because we have a lot of information, not only on balloon sizing, but also on the protection of coronary arteries, for example. So I think that it costs nothing. It's a very minimal amount of contrast needed to do that, and I don't hesitate to do it in all the patients.
So the very last point, but I think a very important point, and I would like all 3 of you maybe have a comment on that, is durability of the valves. Obviously, not only because we're talking about potential extension of indications, moving into a younger age group, what do you actually tell the patient when you talk about durability, or what would be the minimum that you would accept moving forward?
Yeah. So what I tell my patients is that but this valve, this technology has been out there for 7 to 10 years, and that we haven't seen any major issues in terms of valve failure. I tell them that when you test this valve in a pulse duplicator model, it actually performs very well, as good as a surgical valve. I tell them that the leaflets are made in the same way as the surgical leaflets are made, by the same treatment, by the same company, which gives me confidence. And then finally, I tell them that the good news is, let's assume the worst case scenario, and if this fails earlier, we can actually treat you with a less invasive technique whereby we can put a valve in valve. And we now know from partner data that the hemodynamics of valve in valve are actually quite excellent.
Alain?
Well, actually, I share absolutely this opinion, and there is nothing to add. You know, I just would like to mention that when we started implanting surgical and bioprosthesis, we didn't have any idea of the duration of the valve, and the surgeons did not hesitate to implant bioprosthesis as well. I mean, so we are very, very careful, and actually this aspect of durability of the device is probably an important part of the decision to move to younger patients, of course. And but as you said, you know, we have absolutely no argument to say that we have a degenerescence of the leaflets until now. I have been personally following patients more than 6 or even 7 years today without any deterioration of the device. So I think we can be reasonably optimistic.
Thierry?
Yeah, I fully agree with both of you. I think that the durability will be long, and maybe at least as long as bioprosthesis, surgical bioprosthesis durability.
So can I ask you a provocative question? When surgeons talk about durability, we have altogether 43 surgical valves. Granted, surgery is the most important and still the gold standard for the young patients, but we still have 43 valves. The indication for each individual valve to be implanted or approved was, of course, not duration or durability of the valve. It was bench testing. Why do you think this opinion today has changed to years, patient years, instead of accepting bench testing like their own standard? What has caused the surgeons to change their mind in this regard? Thierry or Alain?
They had some bad experience with some new bioprosthesis, which appear to be a failure. You know, so I think that if we have this clear idea of the difference in durability of the certain bioprosthesis, they have to be a little more demanding today about the durability of the device. This is absolutely normal.
But not only for TAPI, for their own valves.
No, for their own valves.
Yeah.
It's a loaded question. I think when there are younger technologies, they're held to a higher standard. I don't think we could get a lot of drugs that are used very liberally approved today without very rigorous clinical trials in the United States. But I think since we came later, we are held to a higher standard.
Thierry, that was a very wise word, right? Do you have to add anything to this?
No, I fully agree with that.
Okay, I think we've covered all the important points. Thank you for having joined us for this wrap-up interview on transcatheter aortic valve replacement. Thank you very much for your time.
Thank you.
Thank you.